Good afternoon, everyone, and welcome. I'm Christy Newton. I am a co-facilitator of the TBC at UBC network. I'm an associate professor and the associate head education and engagement in the Department of Family Practice in the Faculty of Medicine at UBC. And I am joined today by my TBC at UBC network co-facilitator, Lee Yates, a clinical associate professor in the midwifery program in the Department of Family Practice in the Faculty of Medicine at UBC. Thank you all for joining this TBC at UBC network event today. Before we start, I would like to acknowledge that UBC's Vancouver Point Grey campus is situated on the traditional, ancestral, unceded territory of the Musqueam people, and that UBC Okanagan is situated in the unceded territory of the Sayelks Okanagan Nation and their peoples. I would also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining today from many places. And I acknowledge the traditional owners and caretakers of all those lands. I'm attending from Port Moody, the traditional unceded territories of the Quequitlam First Nations. Please feel free to add in the chat and share the lands from which you are attending today. So now I'm going to hand it over to Lee to share more about TBC at UBC Network and today's event.
Thanks, Christy, and hello, everyone. I'm grateful to be joining today from the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. The TBC network is supported by UBC Health, which works under the Office of the Vice President Health to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaboration across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy, ultimately to address inequities and improve the systems that foster and support health. The TBC at UBC network convenes health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas important for team-based care in BC. The network supports and complements province-wide efforts to enhance team-based care in BC by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect their efforts. Each network event applies a different lens to the themes of research, pedagogy, and innovation. Our session today will focus on team-based care and virtual communication and ask, how are healthcare teams and networks innovating with and being impacted by remote presencing technology, including Zoom and FaceTime, virtual sims education, and virtual care? And we'll also ask what ideas and questions are arising for virtually assisted education of health professional learners in team-based care across BC, particularly those in rural and remote areas of the province. We're going to start today with 3 short presentations from our panelists. Each will offer perspectives that reflect the themes of practice innovation, education, and research. Our panelists are John Pawlovich. John is a clinical professor in the Department of Family Practice in the UBC Faculty of Medicine and the Rural Doctors UBC Chair in Rural Health. And John will provide the practice innovation perspective today. Ray Marchal is a physiotherapist at University Hospital of Northern BC, and Ray is bringing us a learner's perspective today. And Jude Kornelsen is an assistant professor and co-director of the Center for Rural Health Research in the Department of Family Practice in the UBC Faculty of Medicine. And Jude brings a research perspective to our conversation today. After the presentations, there will be space for dialogue amongst participants, both in smaller groups and as a larger group. But we'll share more about that after we hear from our speakers. So I will hand over to John for the first presentation.
Thanks so much. Welcome everybody and good afternoon. John Pawlovich here. I'm calling in today from my home here in the Central Fraser Valley, the traditional territory of the Stolo Nation. And I'll share my screen. Thanks so much for the opportunity to present today on some transformative work around team-based care and virtual communication. I just want to start this, my quick introduction to my contribution to the talk today around really transforming healthcare access and support through an equity lens for our most vulnerable communities, really communities that are the furthest away from traditional resources, such as the picture on the left-hand side, which I think epitomizes I say this respectfully, the Ivory Tower in downtown Vancouver, Vancouver General Hospital, where teams of people can be fairly easily mobilized to help with a critical patient, sometimes not so critical, but there are scores of people who are present in a place such as Vancouver General. And if you juxtapose that to the picture in the middle, which is the community of Takla Landing in the Takla Nation, which I have the great privilege of helping to support care there over many years. It's a very different type of environment to provide care, but also as a learner. And I'm sharing the picture on the bottom right corner, which is a recent picture in 2022 of a critically ill patient in Takla Landing. And the noteworthy part is around in addition to the EHS crew that kindly came up after 14 hours of battling up the roads to get there because people couldn't fly, we had two residents, one a pediatric resident from UBC and one a second-year family practice resident, who were gaining firsthand experience about what it's like to help support and manage a very complex, critically ill patient. What you can't see is at the foot of the bed is an iPad with a virtual physician, an emergency room physician, known as the Rudy physician through our real-time virtual support program in BC, that's helping support this patient. And this patient was in Takla for 14 hours before help arrived and was extremely ill. And very interesting reflecting with the learners around what that experience was like to be in a very low resource setting, both from a manpower perspective, but also understanding that we didn't have a lot of anything and that many of our medical procedures, the medical care that we customarily give in larger centers, we couldn't give because of the limitations of access to these types of supplies. So the real-time virtual support program, many on the call here may have heard about it. This is a pan-provincial program that's really stepped up during the time of the pandemic to really address some of the glaring inequities in our healthcare system, specifically focused for rural, remote, and Indigenous communities. And if you think about that rural community, the Indigenous community in the center, we have these kind of orbiting moons, if you will, that provide a wraparound 24/7 access to emergency care support, one-on-one, not unlike what I just showed you the picture of. And we have emergency medicine, maternity, pediatric care, and currently undergoing a rebuild for critical care. The support for learners that I touched on is really important. I think we're entering a time in history where we're able to support learners in ways we haven't been able to previously due to some of its culture, but some of it is simply technology itself hasn't advanced to the point where a learner can hit a button and have a preceptor or a colleague or a peer appear in real time to help them walk them through a question or a procedure or the like. We have had over the last 2 years experiences now with family practice residents, for example, going to Takla Landing, the community I showed you at the beginning, without a preceptor physically with them. So without myself or another colleague who would normally take a learner to Takla, we're now able to allow senior residents to go to a community like TACLA, obviously with a preemptive understanding and experience of a place like TACLA, but to be able to go there as a learner, as part of their learning journey, and experience what it's like to stand there in your shoes in a rural, remote, indigenous community without a preceptor at your side. That's a very different experience for people to imagine, and how you think, how people react to you is very, very different. So I think this is a very special time that we're embarking on. The challenges, of course, are, I'll finish here by saying it's hard to move mountains of culture. So it's very hard for us to break away from that which we know, the ways we've been trained, the way we've been practiced for decades in some cases. It's very hard to interrupt that way of being, so to speak. The other part, when we're talking about virtually supporting people, is that we ourselves are very inexperienced and lack the knowledge and the expertise around being very competent and confident virtual healthcare providers or educators. I think it's fair to say we're thrust into this virtual space with at the beginning of the pandemic. We're coming up on the 2-year anniversary of it all. We're still feeling very, anxious about how this is all going to go into the future, embracing a hybrid model of both care and education. So digital health literacy, both for providers and for our patients and for our learners, is something that we need to consider. The other glaring challenge we have is that we have a great inequity in the infrastructure around the province. So if we want to support learners, if we want to support colleagues in our most vulnerable communities, we have to understand the access to broadband connectivity is not equitable. And so the resources in communities need to be considered, and we need to advocate for the proper broadband connectivity for all of our communities, all our rural, our remote and Indigenous and our urban communities. We need to have that broadband connectivity and the resources to support it across our province. And that's obviously speaks to the availability for patients as well, with respect to the hardware that they need to utilize in order to access care. So I'm going to stop there, and I'm going to ask Ray to continue on.
I'm Ray. Thanks, John. I think we have a lot of similar topics we're going to touch on. So I'm going to be talking about team-based care in physiotherapy education and how technology relates to it. Okay, so a quick outline. I'm going to talk about my personal experience with team-based care, opportunities with technology, challenges, and then a quick conclusion. So in 2017, as part of one of my placements in school, I had the opportunity to go to TACLA with Robin Roots, a physiotherapy educator. And there I saw team-based care in action, kind of for the first time. We were able to share a living space with other care providers, which of course that's not always possible, but what happened was, we built these relationships with these other healthcare professionals, and it really translated to better communication at work. There was also a really functional, useful EMR in place, and clients often were able to meet with multiple healthcare providers at the same time, some via telehealth and others in person. But the thing I noticed most was that there was a culture of respect and open communication that existed between the healthcare professionals there. And I could see that really translated to better care. So then I graduated, and as a new physiotherapist in a bigger center in Prince George, I learned quickly that what was happening in TACLA was the exception and not the rule. Healthcare was mostly siloed into professions, and facilitating interdisciplinary communication was quite challenging. So I'm going to talk a little bit about opportunities with technology. just that I've noticed. Physiotherapy, of course, has always been traditionally quite a hands-on profession. But when the pandemic happened, pretty quickly, clients, other healthcare professionals, physios, and physiotherapy students started to see that the physiotherapy was possible without hands-on treatment. And a lot of people, including Robin Roots, have been doing telehealth for a long time, but this is where it started to really become more mainstream. And a lot of research started to come out showing that it could be as effective as in-person care. And so then that kind of led to this realization that, wow, there's all these small communities in northern BC and elsewhere that haven't been receiving physiotherapy care because they can't hire a physiotherapist there. But we can provide really good care virtually. So why don't we give that a try? So we began a pilot project in Fort St. James, my hometown, and we started delivering telehealth physiotherapy there. We also trialed having an assistant on the other end of the telehealth appointment in the room with the client. The assistant received a little bit of one-on-one training with me, but otherwise they were just a community member who had an interest in health and wellness. And ultimately, it's been received really well. It's been effective. We've been able to provide care to people who had never seen a physiotherapist. And I also think students get a lot out of learning in this setting. They see that virtual care can be really effective. And they also get to practice different skills than they would in a hands-on setting, specifically communication skills. The program works really well because they have a really good EMR in place. And so it's also really important for students to see how a good EMR can really improve care by being able to communicate, read each other's charts, and send quick, secure digital messages. So the other thing, and this is really similar to what John talked about, is in the summer, we trialed having a physio student in TACLA on their own with their physiotherapy preceptors, myself and Robin, in Prince George, but available remotely. So the student was with a medical student and the medical student's preceptor. And so they could ask them any kind of pressing questions, but they met several times a week with Robin or myself to answer any physiotherapy specific questions. And the placement went really well. I think it's for a unique student who's confident enough to take on that role, but it went really well. And I recently heard that 2 OT occupational therapy students will be doing a similar placement in McBride coming up. So this idea seems to be spreading, which is great. So challenges with technology. Something I noticed in my placements, and then that I've tried to get away from as a preceptor, but probably accidentally taught, is learning to be in a silo, learning to work in a silo. I think when we have students, we tell them it's important to communicate, reach out, share information whenever possible, but often we're not demonstrating that behavior. And then sometimes when they reach out to gather information from another healthcare professional, they're met with frustration or irritation. It's a bad time, people are busy and don't have time to chat. But unfortunately, this teaches the student that it's easier to just stay in their lane and only reach out when absolutely necessary. And I think technology can play a role here, because if we had an easier way of communicating with each other that wasn't necessarily in person, such as a secure digital messaging system or even secure email, I think we would have a lot better communication. And I've experienced that EMRs that have that in place really do result in better care. And then archaic communication systems, this is kind of on the same topics. Students are often very frustrated by the lack of convenient communication. We're kind of restricted through privacy policies to using fax, which is slow and you don't really know if the person received the fax, or phone calls, which, you know, you catch the person at a bad time. You call a surgeon and they're in surgery. And so having integrated EMR systems with secure digital messaging will really improve our ability to provide team-based care and show students that team-based care is the best option. So in conclusion, the technology exists to facilitate very good team-based care, but traditions and privacy policies prevent it from being what it could be. Fortunately, the pandemic has given us lots of new opportunities to be creative with technology, to both teach and practice in innovative ways, which will hopefully lead to better healthcare. Okay, and I'm going to pass it off to Jude.
Great. Yeah, thank you. And good afternoon, everyone. I am really delighted to be part of this discussion and excited to see already the synergies that are emerging between practice innovation, education, and research. What I'm going to be doing is talking about some high-level findings from very high level from a study we did about rural maternity care providers' attitudes towards and experiences with virtual care, specifically focusing on tripartite visits. As a way to introduce some more generic questions that we may want to consider actually to optimize virtual team-based care. So the work was done, the Mobile Maternity Project was done funded by the Specialist Services Committee as a proof of concept to basically assess the efficacy of linking rural primary care providers, so physicians and midwives, with regional specialists, regional obstetrical specialists for both urgent and routine consultative support at a distance, so not requiring the patients to travel. The idea was that this connection would also allow for improved shared care of high-risk pregnancies. And it was also available as a safety net for precipitous deliveries that inevitably happen in communities without local supportive resources for maternity care. It also facilitated real-time, or what we call just-in-time, educational opportunities between specialist and primary care providers through the direct consults. But most importantly, and probably most relevant to today's discussion around team-based care, is that the MUM project prioritized a mechanism for tripartite visits, that is, clinical encounters that involve the specialist, local primary care provider, and the birther and family through a team-based care approach. So this is a photo of Dr. Mula, an OBGYN in Nelson, and my clinical co-lead for the MUM project. And one of the interesting parts about the MUM project for me as a researcher was the relatively low uptake of virtual visits that Dr. Mula and the other participating OBGYNs had request for. So although we heard from the rural primary care providers in the communities we were working with that there was a lot of appreciation for the MUM service, it was valued more of a safety net than a service that people were using day to day. So people expressed the gratitude for it being available if they ran into trouble, but they weren't using it on a day-to-day basis. Then the COVID pandemic struck, and it was partway through the project, and all of a sudden, mechanisms of and mandates for virtual care exploded. Based on our experience of the low volume uptake of virtual care in the MUM project, though, we didn't have a really clear idea of provider preferences for virtual care, and we were really keen to seek that out through a survey and a series of focus groups and interviews. We did over 120 across rural BC. I'm going to very quickly review some of the high-level findings because I think they set the foundation for a research agenda around virtual team-based care. So we heard that there, again, the value, value and the appreciation for a safety net to video access regional specialists should it be needed. We heard about the expediting of specialist advice through virtual care, thus accelerating sometimes necessary changes to patient care plans for the better, and this was always, of course, a good thing. We also heard about increasing real-world learning in contexts where shoulder-to-shoulder access to colleagues is diminished due to geographic isolation. So we're talking about most rural communities across BC, and also lots of positive regard for tripartite visits and the role they played in improving interprofessional communication and understanding. So really interestingly, we are of course focused on on reducing the need for redundant patient visits and bringing people together, but we heard from the providers the value of the tripartite visits. So with regards to tripartite care specifically, participants expressed appreciation for improved communication. So reducing reliance on patient recall and ensuring that patients don't forget information that needs to be brought up because the primary care provider is there and they can jump in. So that was seen as a huge win. Also, patients or participants reported the importance of being able to support patients by translating lots of technical information as well as provide moral support. So we heard tons about patients coming back to their primary care providers saying, yeah, I had this meeting with my OBGYN and I have no clue what they said. Or worse yet, getting the information not interpreted correctly. So that increased communication also led to, not having to wait for an official referral letter, which was very helpful. And also opportunities to learn from one another in the consult, which was noted as being really helpful. The main challenge or concern raised was around the impact of trying to gather everyone together. So basically on workflow, scheduling challenges, logistics of coordinating 2 offices plus the patient and family. There was also some concerns over billing with regards to 2 providers being present, and in some instances how that didn't work out completely. So what I've done to end is I've posed some questions through a health service research lens that I think might increase our understanding of how to optimize the value of tripartite or team-based care. So they include, first of all, ones of infrastructure, and we've already talked about that, and everybody's well aware of the challenges, as John has just mentioned, and Ray as well, that stem from poor internet connection, poor cell reception in small towns along highways and hospital buildings, and likewise, of course, in patients' place of residence. So that's a huge infrastructure problem. We also heard lots of challenges with workflow and how the time required to deliver virtual care. In some instances, it's more expedient. You can go and do virtual visits while you're waiting for other things to happen. In some instances, we heard a lot actually about the difficulty of trying to organize the appointment and then logging on and audio and visual problems. Some participants described wasted time trying to troubleshoot, causing delays in workflow and issues with maintaining set appointment times. And my observation is that that only happens once, meaning that people don't usually go back if they have a difficult experience. Their clinic days are too busy to try and figure it out, and they won't do it again. We also, this is an interesting one. There's this issue between a complicated relationship between economies of scale, that is having enough patient volume to keep specialists busy, and supporting the regional referral specialists that will be adjacent but might not be able to answer calls or be involved in a virtual visit on a regular basis because they have their own clinic and work to do. So finding that balance between the centralized support that comes and supporting virtual specialists, which of course are essential if you're going to be transferring to, is something that I think we should look at. It's really important. We heard a lot about the need for education, both from physicians and also from providers, both primary care physicians and midwives and specialist providers, basically to help reduce potential fear and hesitancy around the technology, but also adapt to a new modality of healthcare. There was lots of comments on questions about appropriate fee code, adaptation, whether or not the fee codes that exist during COVID are going to be retained and what it means if they're not, and the very real need to ensure patient consent and privacy without creating unmanageable barriers to access, so long consent forms, etc. So basically the pragmatics of team-based care. So that, in a nutshell, is what we learned, and I'm going to hand it back to Christy and Lee.
Thanks so much to all of our panelists for providing some teasers for our breakouts. So we're now going to move all of you into smaller groups for discussion about some of the things that you've heard, some of the questions that you may have come up with as you were listening to the panelists, and in consideration of your day-to-day context. What questions have you come up with? What questions do we need to be addressing about the role of virtual communication in supporting team-based practice, education, and research? So there are going to be 3 breakout sessions, one led by each of our panelists. It's going to be about 15 minutes. We're gonna adjust the time as we go, we have put together some guiding questions for the breakout to focus the conversation in the breakout room, and that will be in the chat. So again, breakout room is John and practice innovation. Breakout 2 is Ray and the learner education perspective. And breakout 3 is Jude and the research perspective, although you've noticed they've all kind of overlapped. 1, 2, 3, go. And we'll see you back for a large group discussion afterwards. That was great and a little quicker than we had expected. And so we do have time, though, for some sort of summarizing of some of the key questions that came forward in the different breakout rooms. Where's John? He's not on my screen right now. Didn't know, John, if you wanted to jump into the questions that came forward, or whether you wanted me to summarize some of the ones that I heard.
Yeah, I'm happy to summarize a few of the main themes, Christy, and I would say, without question, understanding how technology supports patient-centered care in the full spectrum of education as well as clinical support is vital to this story. So the answers to many of the questions around virtual care are really home with the patient, and so they dictate the terms of how teams are created and leveraged through technology to support themselves and their families. And so the other key component to the story that I always draw attention to, and Robin Turner, just before we broke off, put an excellent couple of questions in the chat, and it speaks to relationships being at the heart of care, both physically and virtually, and so that doesn't change. And so when you think about virtual providers, when we're educating, when we're providing care, relationships are at the heart of that story all the time. It's been proven to me time after time that a patient, irrespective of where they are, would rather see a provider that they have a relationship with, either physically or virtually, than somebody that they don't have a relationship with, either physically or virtually. And so just these are kind of the foundational bits that we need to teach and emphasize with our learners as well as our peers moving forward. So that longitudinality, that patient-centeredness, the relationships are key pillars of building out a solid framework around education and care.
And along those lines, one more aspect before I hand it over to Lee and Ray is again that upskilling piece, which will lead into our next one, right? Is how do we sort of rapidly build foundational competencies in virtual care and virtual technology, and layer in the team aspect as we move this forward, and again equitably provide the resources to do that. So those are the other questions that I heard come forward. And now I'm going to hand it off to Lee and Ray from Breakout 2.
Thanks, Christy. I was the avid note taker in our session, so I'll report back from the notes. And that was an excellent handover, because one of the things that came up, one of the remarks that came up in our group, built on an earlier question, what is the role, or is there a role for virtual education? And one of the remarks was about not only using virtual technology as a modality for teaching, but we need to teach providers, learners, educators about virtual technology so that we all have that upskilling to be able to use it well. And so, two lenses on that question. We also talked about the need for, so along that line, the tech support for preceptors, so that they can use it well in their role as preceptors. We heard about a study that was done 5 or 6 years ago in the United States, where midwives were using video conferencing for labor assessment, with look at that use then in the COVID environment in British Columbia. And what was heard from preceptors and students was that clients weren't particularly interested in the use of virtual technology, particularly through video. And whether that comes from privacy concerns, access, technology, a number of the things that we've named, but that we need to, hold a position for client willingness to use these technologies. We talked more about culture and around what counts as a meeting or a patient interaction, and with virtual technology, how do we bring accreditation up to speed so that counts. And then there was a really good question. Someone talked about tech being desired for many years, and then we were thrust into it. And so now the question is, when do we use it best when it's not our only choice? So through COVID, it was our only choice. We had to use it. Now that it's become a regular option, how do we look at what's the best practice? When do we use it best? When it's one of the suite of options that's available. And then the last piece was a remark about students being on site, potentially on site in a remote community attached to their preceptor virtually. And how do we ascertain the skill of students and protect students in those environments, recognizing that there's a critical role for team-based care there. And it's really the setup of a well-functioning relational team that is an enabler in that environment. And I think that's everything. The very last thing that I'll end with is, again, relating back to culture, how to get preceptors and learners on board was asked, and how do we change the culture to value virtual technology and the best practice and the potential benefit of it.
Thank you.
Yeah.
That's great. Okay, Jude.
So, there was a recognition of the focus of team-based care right now and virtual team-based care on primary care, which is totally appropriate and helpful. But we talked from different perspectives about moving beyond primary care. For example, dietetics, to try and make, create an infrastructure for dietitians to be available, which is a huge lacuna across rural communities for sure. And also to try and, figure out how it can be integrated into not just primary care, but community care as well. And the value of having more folks in the community be engaged in team-based care discussions, I guess. There was some discussion about virtual mental health care and the idea of it not meeting people's needs, and we need to start looking at how to include people in the development of team-based care models and virtual models, because in many instances patients and clients weren't engaged, and that was the problem. There was some really interesting stuff we learned about coming out of the Innovation Support Unit, where they're developing tools for nurses that we might maybe be able to learn from. If it's establishing a best practice across BC, we can see if it can be adapted to other areas beyond nursing, etc. There was also a recognition of the importance of facilitating low barriers to access and questioning and looking at the ways to do this, to make sure it's very easy for people to get online and not provide any barriers at all. With busy clinics, etc., people are not going to try and do it again if they have difficulty. The importance also, we talked about the importance of understanding, probably through research and evidence, how to prepare healthcare workers and patients to have an optimal experience of team-based care and a virtual team-based care for sure.
So you're going to see a poll in front of you because we are quickly running out of time, down to our last minute. We're we're asking all of our participants what they would like us to think about for our next session. There's so much going on in team-based care, education, research, practice. There's so many questions we're generating. There's never enough time. So we need your help to guide this, to guide the network in what you want to talk about and learn about and ask questions about. And so we want to thank all of our panelists for joining us today. We really appreciate their time. We really appreciate all of you joining us and having the conversations and asking the questions. We also have an announcement. I think Lee.
Sure, thanks, Christy. I just want to let everybody know on your way out the door that the UBC Health Hi-Fi Awards, that's the Health Innovation Funding Investment. The next call for proposals opens on February 15th to faculty members at UBC, Vancouver, and UBC Okanagan. And in addition to the general open call, UBC Health is inviting applications that focus on initiatives that could contribute to provincial efforts to establish and enhance team-based care. The call for proposals will close on April 15th, and everyone in the network will get an email in the next week or so with more details. And I think that's it for today. That brings us right to 1 o'clock. And I echo Christy, thank you so much for joining us today. And lots of gratitude and thanks to our panelists for engaging in the conversations and for their presentations and sharing their ideas and thoughts. And we look forward to seeing you at our next network event, and which will happen, I think, in a month or 6 weeks from now. I'm not sure that the date's set, but it will come soon. And thank you.